So got some room to work with over here.
The patient is wearing shield.
Thank you.
I thought we were doing imaginary, that's what.
No, let's not do any imaginary shields here, especially not while I'm on camera.
Oh.
No, we want to
Okay.
do that to you, that's all.
So, for the ankle, where do we center? The
Mid
Mortise
ankle
joint. How do we find
Between
that?
the lateral and medial malleolus.
That's right. All you do is you find the malleoli right here, and you center right in between. Okay. So, probably one of the easiest ones to palpate for. Alright, sorry, I'm just gonna slide this over. Alright, in this case, right, I want the leg, right, long axis of the leg, once again, to follow this all the way down. Right, I want this foot to be in an AP, so be careful not to let it turn out this way, right? When it comes down, it should be following it all the way up through the third, right, through the center of the foot. So, I'm gonna rotate you just a little bit. Lift up. Slight turn. Very good. Right, so down the center, up through the third. Right. Now, this is where things get interesting. The position of the foot. Marrows, and most texts, especially the old school texts, will tell you that you need to dorsiflex the ankle. So, you can't leave the foot like this. You need to take this foot and have the patient try and pull it back like this as much as possible. Try and get this as vertical as you can, right? Dorsiflexion. And then you collimate in, and that is your AP ankle. However, there is a note in Merrill's that says that recent studies have shown that dorsiflexion doesn't actually improve the image all that much. And there is a big danger with dorsiflexion. If the patient has trauma and you're forcing dorsiflexion, you can injure the patient. Does that make sense?
Yes.
So, for patients like this, right, always check to see how much they can comfortably do by themselves. Do not ever force them into a position, right? So it's like, all right, are you able to bring your toes back? Right? If it hurts, just stop, right? But bring it back just as much as you can. That way, the patient will decide how much dorsiflexion they are capable of doing. Right? If they can't dorsiflex all the way, no issue, right? Like I said, it doesn't actually improve the image that much. So just as much as the patient is able to do. Make sense?
Yes.
Okay, good. So just make sure our ankle is properly rotated. Collimate in, collimate in. Keep that rotated. All right, lateral side.
And you're orienting the marker of the face with the green strip?
Yes, Marker Shaw is pointing up towards the green strip. Okay, collimation. Merrill says just get about 10 centimeters. No, sorry, 10 inches of collimation. Right, so you're gonna go maybe about a bit less than a third up the way, up the fib. All right. Any questions here? Good so far? Great. Oblique ankle. With the oblique ankle, there are two types of obliques. What are they?
Internal and external.
No.
No?
These are both medial obliques. But we have the Mortise and we have the true oblique. So, what is the difference?
A Mortise opens the joint space.
The Mortise opens the joint space. Great. And the true oblique?
Just 30.
Superimpose?
So, we should specify which joint space we're
Right.
talking about. So, the Mortise opens up the ankle Mortise joint space here. The true oblique opens up the distal tibiofibular joint. And it shows the posterior malleolus.
Okay, that makes sense.
So, The Mortise, you're only gonna rotate about 15 to 20 degrees medial. The true oblique will be 45 degrees medial. So let's take a look at the Mortise first. From here, I'm gonna turn, great, I'm gonna slide it towards me, adjust a tiny bit. Right there. Okay, and then sorry, lift up a little bit, I'm gonna move the board. Thank you. Okay, great. So, ankle Mortise, right? Slight rotation, right? About 15 to 20 degrees of rotation. How do you know when you reach 15 to 20 degrees of rotation? Rule of thumb, right? Tech trick is that if you're coming down the middle of the leg like this should exit here around the 5th digit. Does that make sense? Right? So if you follow this line, if it's coming straight down the middle of the ankle, it should exit around the pinky toe. Okay, so that's about 15 degrees.
Do they still keep the foot dorsiflex, or is it just kind of like relaxed?
So in this one, they can leave it relaxed.
Yeah, I was gonna say my foot is, it's
Yeah.
relaxed.
Good luck trying to, yeah, it's gonna be real tough to dorsiflex like this. Alright, so this is Mortise. Now, for our true oblique, we're gonna go even further. So I'm gonna have you turn your leg, turn. Good. Okay, and remember, when you do these, do not just try and turn the foot. Right? This does nothing. The entire leg needs to be rotating. Does that make sense? Right, so don't just turn the foot, make sure you are turning the entire leg when you do this. Alright, so 45 degrees. This is our true oblique of the ankle.
Can you see?
Yeah, we see what's going on.
So far so good? Great. In
Good.
that case, let's do our lateral ankle. Go ahead and turn towards me, Reagan. Just a little bit. Good. Right. Positioned very similar to your lateral foot, right? So slight bend of the knee, slight turn. This time, where do we center?
On the malleolus?
Yes, we center directly on that malleolus. Okay, so. Okay, center to my IR. Okay, malleolus right here. So I'm going to dorsiflex the foot. Good, as much as you can. And then I'm going to slide the foot slightly up until that malleolus right here is in the center. Okay. Now, once again, if I put my hand here, I'll notice that the foot is slightly turned this way. So I'm going to take the knee, just raise it up slightly so that it is where it needs to be. Okay. So, legs actually more like this. I'm going to turn the IR to match. Collimate, marker. All right, lateral ankle. Any questions? Okay. Very good. You can relax,
SID is
Reagan.
okay.
SID is at 40.
I mean, the OID is okay.
So, OID with the leg, that's normal as long as the foot